Well, hello everyone. I'm Bambi Francisco Roizen, and welcome to Invent Health. This is a program brought to you by Vader, HP, and UCSF Health Hub. And we've been running these salons quarterly for the last 3 years, and typically we're at HP or UCSF. But 2020 has been a very surreal year, as we all know, and with lots of surprises, including a very apocalyptic disquieting orange yellowish sky. And as I was saying to somebody, I feel like I'm walking around with a vintage filter all around me. So very sobering and spooky out there. So since we are hosting these events online, and hopefully we'll be back in person in 2021, but since we're hosting these events online, we're hosting these extra sessions as a way for the panelists to meet and greet one another. All of you are on different panels. So before that main event, which is a reminder, October 7th, between 12 p.m. and 4:30 p.m. PST. So put that on your calendars if it's not already on that calendar, on your calendar. But today we are kicking off the discussion, and today's topic is healthcare in politics. So typically Arshana and I do lead the discussion, but because we want to make this a conversation, a very fluid one, please feel free to raise your hand, ask a question to your fellow panelists, and maybe even make a comment if you'd like, or take it even a different direction, but don't hesitate to do that. You don't have to wait for us to call on you. So with that, I want to quickly hand this over to Arshana, who will then hand it over to Mark, who both will say a few words. So Arshana, take it away.
Welcome, everyone. Thank you, Bambi. I'm Archana Dubey. I am a physician by training. I work as Global Medical Director here at HP, as you could see from my beautiful printed background, hopefully not showing off the sky that's right behind me. Just wanted to welcome each one of you and have a very deep discussion around healthcare and politics, or more so policies that influence healthcare, and how they're impacting our current environment, especially as we are in the midst of a surge, so to say, of a pandemic that's surrounding each one of us. From East Coast, we have a couple of panelists joining, all the way to West Coast, a panelist joining from here. So welcome, and I'm looking forward to the discussion today. With that, I want to pass it on to Mark, and then Mark, if you can pass it back on to me, that would be awesome.
Great. Hi, everyone. Mark Goldstein. I am the chairman of UCSF Health Hub Innovation Center at UCSF. We love co-sponsoring these events with Vader and with Arshana and Bambi, and we've been doing it for 2 years, and we regret not being on campus in Mission Bay with 400 or 500 people, which normally we would be with, but we're here. And the topic here is great. There haven't been webinars on this topic, so I think this is going to be a great October 7th event and a great kickoff. A little bit about Health Hub. We have about 15,000 members now, so we're growing nicely. These are companies, advisors, investors, really people that are super excited about the future of healthcare and digital health. Biggest thing we have going is actually later this month. We have our second annual Digital Health Awards on September 23rd. So if you haven't signed up, please do. Just come to our website at www.ucsfhealthawards.com. I'm looking forward to this. I know a number of you panelists. This is really a great group, and we're in really good hands with Bambi and Arshana, and I'm going to hand it back to you guys.
Thank you, Mark, and I'm also looking forward to the award session too. So with that, I want to jumpstart a conversation very similar to how we do it in the Invent Health style, is to have everyone introduce themselves and talk about how your perspective on how you look at healthcare in politics or policies, and share your perspective, how you're seeing it, especially in this environment of COVID crises. On my Zoom panel, I see Amber as number 1 on my right side. So I would start with you, Amber.
Sure. Hello, everyone. My name is Amber Hewitt. I am based in Washington, D.C. I am the Director of Health Equity at Families USA. We are a national nonpartisan health consumer advocacy organization, and we are dedicated to achieving high-quality, affordable healthcare and improved health for all. And in my role as Director of Healthcare, we work to advance, policies that center equity. So we envision a nation where no one faces a barrier to achieving optimal health based on who they are, where they live, or how they identify. And as we know, this pandemic has exacerbated existing health inequities. So that's the lens that I will be bringing to this conversation.
Thank you, Amber. Welcome. And I would love to hear your take on to how the policies are impacting, especially on health equity. My next panelist that I'm seeing is Joel. So Joel, can you introduce yourself and then talk about how you're seeing healthcare and politics from your lens?
Sure. Joel White, I'm the president of Horizon Government Affairs. We're a consultancy here in Washington, D.C. We represent a broad spectrum of stakeholders across healthcare industries. And we also run two coalitions. One is focused on creating affordability for consumers and making sure that costs rise more slowly than income. And the other is focused on really taking data and technology and using them in healthcare to make healthcare work better. And I would say our biggest perspective, having been in DC for about 25 years, I've never seen an argument as strange as this one. The data and the science seem to have flown out the window, and we're not really using real numbers in kind of thinking about the policy response to what's happening on the ground with COVID. And so really focusing on how do we get better information, better data, and better science re-injected into the policy discussion so that we can make good and rational decisions to respond.
Great, thank you. And we need more of your kinds of people who talk scientific and data more into the policies. With that, Duncan, could you introduce yourself and share your perspective?
Hi, Duncan Davidson, Bullpen Capital. What do you do in California? You're either in the movie industry or the tech industry. So we invest in tech, obviously. We're doing more and more digital health investments. And digital health means the software or the data side, not the actual med or the med tech equipment. So what we see here is an utter failure. The Heritage Foundation report was right, but utter failure at the data side. The data is badly collected, misleading, the metadata isn't attached to it, et cetera, et cetera. And you say to yourself, why can't we have the type of data system that most industry has going through the government? Now, maybe that's a self-answering question, but we could try to do better. The other thing we're doing right now is we've been working with small business groups and minority groups to try to enhance small business creation and success among the non-tech people. In particular, what I've been most appalled by is the high propensity of certain groups to get COVID and die from it, and not just the elderly. So we're trying to get more focus in those areas in our own investing work and see if we can do something to change the curve a bit.
Great, thank you. Phil, I see you next on my screen. And you're on mute, so if you can unmute yourself, that would be great.
Okay.
Thank you.
Phil Kerp and I run two organizations. One is a 501c4 called American Commitment. We do sort of free market policy advocacy and analysis, and we try to focus on kind of the policy issues that are on the margin. And we don't do a lot of original research. It's more sort of short to the point kind of bulletin type material, and we try to get into the hands of citizens to be more active, engage citizens on policy issues, and sort of tip things that are on the balance, either legislative or regulatory fights, in kind of a more free market direction. And we work really on all the fiscal, economic, and regulatory issues, but healthcare is kind of one of the big issue areas that fits within that. And then I also wear another hat. I'm also the president of a 501c3 called the Committee to Unleash Prosperity that was founded by Steve Moore and Art Laffer. And they brought me in really around the beginning of the pandemic to focus on kind of fighting back against the heavy-handed lockdowns, which have had such devastating negative economic as well as public health consequences, and fight for more rational policy responses and sort of educating the public in that regard. And we do a daily newsletter with that. And I would say that my main focus with respect to coronavirus has been on kind of the shape of the at-risk population relative to the exceedingly low or near zero risk. And so I started tracking long-term care deaths on May 7th. I think I was the first person to do a daily tracker, which I still maintain, even though some other people are probably doing it better than I am by now. I still maintain it out of habit every single day, updating everything and all the numbers and looking at the trends. And sort of the other side of that coin is the exceptionally low risk to children, much less than seasonal flu, and yet the irrational fears that we've had and imposing enormous hardship on our children with school closures that have been open-ended and a lot of misleading fear and panic that's been imposed on them. And so I've really been focused on trying to get an accurate view of sort of the numbers and the data, and to lift restrictions on low-risk activities, and to focus on sort of better targeted interventions than sort of the blunderbuss lockdowns and continuing kind of phased restrictions that I think have had a lot more harm than good. And so I'm probably the sort of the right-wing anchor of your panel, but that's such as it is. Those are that's what I've been doing.
Hey, Archana, I just want to say in response, Phil, you should really not be so shy about your thoughts and opinions. You need to.
That was about as muted as I can be in presentation of it. I had a very angry conversation with my kid's school principal for about 45 minutes today, and so I'm screamed out. Actually, that was my mellow, that was my mellow version.
Yeah, the mellow version. Well, I would say that there are no wings on this Zoom call, so so let's just kind of talk all wings, so to say, on this call. And with that, I would like to also invite Esther for this discussion. So Esther, can you introduce yourself and share your perspective?
Sure. I'm Esther Dyson. I founded Wellville back in 2014. It's a 10-year, 5-community nonprofit project to basically show how important it is not so much to provide health care, but to foster health and make health care less needed. The people that Phil is talking about, the ones that are at risk, those are mostly people who are unhealthy. Some of them are very old. Many of them are young, but obese or immunocompromised or something else. And many of them didn't need to be. So in our society, we're now destroying lots of people before they reach adulthood. Just bad food, bad parenting, bad education, and it's extremely expensive. I mean, Phil, you probably think rich people shouldn't be taxed quite so much to pay for all these poor people, but they are being taxed because all the poor people are getting sick because we're not investing in public health and we're not investing in public education. So I'm one of the people who really cares more about policies than politics, but we need to think about this long term. My work is not focused on COVID-19. It's focused on creating an environment where COVID-19 would have much less impact.
Great, thank you. So with that, I will pass it on to Bambi.
Okay.
What about Molly?
Well, we have Sally.
Oh.
Sally Pipes.
Oh yes,
too.
there you go, Sally Pipes. Yes, I'm off my screen.
So, off my screen too, because
yes.
she's not. But I'm not quite sure. She might have walked away, and I don't know. I was going to text her, but she'll join, and maybe Kristen, you can email Sally and ask her if she is actually going to, if she maybe stepped away and if she's coming back. I'm sure she's coming back. So we'll have Sally introduce herself once she gets on. So, well, I do think, I want to say something about, just comment on what Esther and Phil said. I think both sides do want to approach and help communities for sure. I think there's just different policy approaches in terms of how do you invest in the communities. And certainly both sides of the aisle have had initiatives to do that. So, but I want to start with schools because I think, Esther, you mentioned that and it's relevant. Archana and I went back and forth as to how we wanted to start this. For me, I have 4 children. I have one son who is going to a private school, but it is still Zoom, I call Zoom school. My sister is fortunately in a school where they're in person, and Trish, who's supposed to be on here, her kids are also in person. She's out in Connecticut. But I want to give you, I sent everybody a graph that I found through a friend on Facebook, but it was very relevant. And this is about schools. So I want to talk about schools because it's September, and I think for anybody, well, clearly Phil has had his shared his thoughts about how he feels about Zoom school. But everybody who have kids, you know what we're thinking about right now, school. So I just want to mention that by not attending, as you all know, this has a negative impact, not on just kids who are kids of those in the knowledge economy, but particularly kids whom Esther is referring to, and those low-income communities, single-parent homes, they're disproportionately impacted by kids not going to school. And recently there was a study that showed 29 universities with nearly 26,000 COVID positive tests, but 0 hospitalization rates. And then in July, the CDC said it was important to open up schools, and quoting the CDC, so far in this pandemic, deaths of children are less than in each of the last 5 flu seasons, with only 64. The rate of infection from school children to teachers is low. My question to everyone here is, what can be done to get our schools open? So Amber wants to start. Yeah.
Amber wants to start.
Yes, I wanted to jump in because if that's okay, I'm definitely going to touch on the schools question, but I definitely wanted to build off of what Phil and Esther said about the economic standpoint, because, you know, the moral imperative I know doesn't appeal to everyone, but thinking about sort of health equity and health disparities by sort of not addressing disparities in health and health outcomes has huge costs. You know, there was one study that showed that the economic cost of poor health outcomes, particularly for communities who've been most marginalized, is upwards to 135 billion. And that by really addressing health inequities, we can add billions of dollars to the economy and jobs. So, and also by not having sort of comprehensive healthcare in this country, you know, we see many people going to the emergency room, which is rising, you know, healthcare costs. So just wanted to add in that perspective to the conversation. But when it comes to schools, I think we also have to, you know, keep top of mind the health of children, families, and schools, school administrators and staff is top of mind, and also realizing that schools can either slow the spread or speed up the spread, and also just putting everything into context. So this may not directly answer your question, but I just wanted to throw this out there as far as a framing. So, you know, similar to the disparities that we're seeing for sort of Black, Indigenous, Latinx, people of color, rural areas, we also see inequities in the education system. So whatever a locality or a state or a plan has, making sure that it addresses some of the, you know, the just inherent problems within some schools. If kids are going to a school building, say with poor air quality, we know that poor ventilation is not what we need right now in addressing the COVID-19 pandemic. So just kind of just wanted to put that sort of contextual frame on the question.
Yeah, and Amber, to address that a little bit deeper and also from slightly different lenses, that a lot of especially healthcare needs, especially speech therapy, mental health, special education, is very much dependent on the school system too. And as we are becoming more a Zoom education scenario, you know, it is taking those essential elements away, and in a space where health equity is already skewed, and if we add this onto top of COVID-19, all of these resources falling apart for that child, it also impacts their physical health and growth in the long run too. So it is putting it on the parent or putting it on the school without providing specific guidance does become an important failure, so to say, of the public health system. And as we are building policies and discussing policies, we also need to look into how are we supporting schools to bring kids back to school, especially for these critical needs. I mean, meals. For some kids, a healthy meal is school is a source of healthy meal. Some of the kids may not even have laptops or computers to be able to attain their Zoom education. So those are things that we are seeing as a disparity, now expanding that gap even more as the COVID-19 becomes a reality with homeschooling. So do you?
Can I throw a comment in on
Can I?
this? Sorry, yes, so just very quickly. My daughter's a teacher in the California public system. She's got three kids, but two of them are at school age. And I think she is now in favor of reopening the school, whereas 2 weeks ago she wasn't. Why? The ones who are at home are extremely depressed. They want to go to school. And so now she has changed her point of view to, okay, teachers will wear masks, will do safe stuff, will make sure they're okay. I tried logic on her. What about essential workers? Two-parent family, one's got to go to work, one's got to stay home, loses his or her job. There's a lot of negative things beyond the food for kids and all that, and the lack of equality in terms of electronic means. But in the end, what seems to be grabbing her is her children are being affected by this, and therefore, let's see if we can change it.
Yeah.
I think just to add to that, I would say that, the direct answer to this question is we really need to get our wits about us, because what the data shows us is that if you are under age 25, there's been 400 deaths, and most of those have been due to Kawasaki disease. That young children really are not at high risk for profound health consequences here. And so having the schools closed is having a profound effect on children, and that is in terms of mental health and their societal development and their education. And we need to weigh that against the risk of the potential health outcome from COVID. And the potential negative outcome from COVID is very, very small. The very real impact on these children is happening every day, and by having the schools closed or remain closed. So that's kind of point number one. Point number two, I just kind of push back a little bit on Amber on the availability of comprehensive health care, particularly for kids. I mean, I think what we see is a very robust Medicaid and CHIP system that's available. I think what COVID has exposed, though, is the fact that those programs are in desperate need for reform, that they are very focused on acute care and not focused on preventive care or wellness, and that those ought to become priorities, because really these big kind of clunky old entitlement type programs don't work very well in a nimble economy and a nimble system where we need to change the focus to more prevention, less acute care.
Esther has a point that she wants to bring in.
I mean, there's a bunch of points. One, it's not just the danger to the kids. They are often quite contagious, even if they're not symptomatic. And so there's the danger to the teachers. There's the danger to the other people in the families of the kids. I mean, personally, I'd like shut down all the bars and figure out how to open up the schools. I think we've got a lot of priorities messed up. The problem is the schools are a mess anyway. We need to do them better. And it's the poor kids who have crappy schools that don't get, all the kinds of things Amber is talking about in the first place. I'm not sure how much good, it's very complicated. I think we should have more schools being available, but I think ultimately the parents should be deciding what risks they want to take with the health of their own family members, what the trade-offs are. But if we had a well-running system, there's too many, if only we had done the right things before, then it would be much easier to do the right things now. What we need to focus on is starting to do the right things now so that the whole system is better, so that we do get actually effective health services provided through the schools, so that we defund predatory health care in favor of community-based health services that keep people healthy rather than waiting for them to get sick. And what we need to fix now is candidly much better information, much more widespread effective testing, and then helping people with good information to make decisions that suit them. but the fundamental decision is don't affect the other people.
Phil, did you?
And
Phil,
Yep.
did you?
Phil had a, yes.
I would disagree with the characterization that children are contagious. In fact, we see precisely the opposite in a now overwhelming amount of data. And in particular, Mark Woolhouse from the University of Edinburgh and a member of the UK SAGE Committee, one of the top advisors to the UK government, has said that reviewing the literature from the entire world, they are yet to find a single confirmed instance of transmission from a student to that student's teacher, not one anywhere in the world, which is really remarkable. It's not to say it hasn't happened anywhere or it won't happen, but do you know how exceedingly rare an event has to be to have not made a news story anywhere, to have not been discovered anywhere, to not be part of any study or any data set anywhere in the world? You have to be talking about something that's really an exceedingly rare event. And that's consistent with what we've seen in terms of contact tracing studies and other studies of infectivity. The best that we have is the one from Iceland, where they actually did haplotyping to determine the direction of transmission. It's the only study that did that to definitively determine the direction of transmission. And they found 0 child to adult transmissions from any child under 10 anywhere in the country, including to parents. And for children 11 to 18, they found 2 instances of infecting a parent and no instances of infecting an adult other than a parent. And so we don't know the exact reason that children seem to have such low infectivity, but we now have a very large amount of empirical evidence that it's the case. And almost everywhere that we've seen what appear to be clusters in schools, it's really a reflection of community transmission rather than the school itself being a setting where transmission is occurring. And the one exception that the one sort of apparent exception that we thought we saw to every single country opening schools with no impact on community transmission, no clusters of cases of any significance, was in Israel, but there were a lot of confounders there because they had opened up large events like weddings, a lot of other things at the same time. They actually had school in session for a couple of weeks before the Shavuos holiday, and it was really after the holiday when there were a lot of holiday gatherings that things started to take off. But what was really striking to me about the Israel data was a report that the European CDC put out in which they found that of all the, the 150 or 200, whatever those initial cases were that were identified in the Israeli schools, they only found 1 secondary transmission in the school. It was a child-to-child transmission. So they only found, even from a very large number of community transmissions coming into the school, of course, 0 student to teacher and just 1 instance of a student to student. And so schools are not a high-risk setting. The CDC has been very clear that they never recommended school closures. This was really a sort of a moral panic and contagion and sort of a paranoia. And frankly, even where we've seen no containment measures put in places like Cherokee County, Georgia, where we had the big panic about a picture in a hallway, well, they've been in full-time school for 5 weeks now with no masks and no distancing. And with 44,000 students, I think, or 42,000 students and 5,000 staff, so 47,000 total. They presently have 27 active infections. We're not seeing what people said we would see in Europe. We're not seeing it in the United States. We're not seeing transmission in schools with or without containment. And we are seeing severe suffering every single day for the children who are being denied. And I agree with the gentleman who said that it's a mental health crisis. We have data for 18 to 24. We don't have data for kids yet, but for 18 to 24, 25% seriously contemplated suicide in the month of June. That's up from 11% in the last pre-pandemic data we had, and 11% was already a crisis. So we were already at a crisis level of suicidal ideation when we were at 11%. Now it's more than doubled because of the disruptions that we've seen for young adults. And based on statements from Robert Redfield, he hasn't released the data, but he said publicly that we're seeing in the school age demographic as well, far greater increase, just the excess of suicide and overdose deaths than we are seeing total COVID deaths. So I believe that the school closures and lockdowns are on net killing children. They're certainly not saving them. And we also have a lot of evidence that to the extent there is any child-to-child transmission in the schools, it's less than we would have in child transmission in the home setting. And the UK recently had a study that compared students who were at home during the summer to students who were in summer school. They found no difference between the two. But in Sweden, where they never closed schools and never put in any containment, they actually have among the lowest pediatric infection rates in the world. And so I think we're really overthinking it. We sort of backed ourselves into this when all the schools closed, even though the CDC never recommended that. And we're sort of tripping over ourselves to get out of this trap when it should be a lot simpler.
Yeah, Amber,
Amber has a, yes.
I want to bring this up as well, and thank you for all of that information, Phil, and all the statistics. But as Duncan texted me and said Esther had the best line, and I guess this is what we should be. Maybe we're overthinking. What we should do is close the bars and open up the schools. So
Yes.
if we can figure out how to do that. But I do want to say, and it's not just the kids. I have 4, so I totally I
have 4 also.
understand the challenge that they are dealing
Parents.
with, trying to just figure out life. And we're very fortunate, but there's some who are very not as fortunate. But I think of the moms, the single parents who have to actually take care of their children, have to work, and also have to educate their children. And some of them don't even have they don't have iPads or the electronics. So I'm a little bit worried about them. So I wanted to ask Amber and Esther. We're in my area. There's 3 charter schools. One is open. Actually, one of my sons used to go to that school. They're putting up actually these. I guess what do you call those separators, like they're doing
Dividers.
The dividers, yes.
Restaurants, but
Plexiglass dividers.
yeah, it's an option. It's an option for the kids. And so my question to you is, especially in your communities, and Esther, in your communities, what's the idea about you talked about investing in public schools. There's potentially a lot of money going into charter schools, like the one in my city, in my town, that is benefiting in lower income families and the kids and the parents by offering all these different options.
So Amber,
Esther,
yes.
Yeah, if it's okay, I was going to go and I can turn it to Esther. I just had a clarifying point. I'm definitely for kids being in school with the caveat that it's, that we're following proper guidelines and that it's safe and effective for all. And I think I may be the only mental health professional on the panel. I'm a psychologist by training, and I've provided psychological services in school. And I definitely understand that children not being in school is very disruptive. Suicide was also mentioned. It's this month is Suicide Prevention Month, so I definitely think it's important to bring up the mental health aspect. I'm not a parent, but I'm the aunt of 4 kids. I have little cousins that I consider my nieces and nephews, but 4 children, school-age children, who are all in school right now in public school in Louisiana. So I definitely wanted to clarify that point, and also give a shout out to the American Academy of Pediatrics. They've been working with partners, releasing guidelines for the safe opening of schools. So my sort of 2 main points before I turn it over to Esther, and Esther, I did love your line that Bambi referenced, is to make sure that plans are nimble and flexible to respond to sort of what's happening currently. And Bambi, as you mentioned, making sure that all kids are able to be learning at this time. I mean, I definitely think, long gaps in learning, we all know the data and the impact on that, making sure that there is proper funding for schools to implement the proper safety measures and for all students to access virtual learning.
Yeah, so for what it's worth, Phil, I found your data really interesting. I've heard some of that, and I feel a victim of what we're all getting, which is all these conflicting stories and bits of data. If it's quite as clear as that, I'm surprised, but I'd love to learn more. No, I'm not asking.
Okay.
But clearly, I agree with you entirely that the worst impact of COVID-19 is the long-term impact on the next generation. And we're making a mess of it, clearly. To me, one of the biggest challenges is, charter schools are great, but they are the kind of solution that absolves the public of creating a better solution, which is we really need to redo how we do the funding of public education. We need to basically make it better. We need to allocate it better. We need to do a much better job of reaching all the kids. And my concern is that we're exacerbating the inequities as well as the problems overall right now. And that's the thing that really concerns me, because you know, the rich kids will do okay one way or another. Not all of them, obviously, but it's the poor kids who, you know, Medicaid and all those things, they don't solve this problem. They don't reach enough kids. They reach that sort of middle group that know how to get access to them, but we're really exacerbating the problem at the bottom end. And, you know, yes, let's open the schools, but there's so much else we have to do as well.
Yeah. And I think with that, I also wanted to invite Sally, who joined us a little bit later. Sally, if you don't mind introducing yourself, and then also we cannot hear you. I think you're on mute.
I'm not.
Oh,
There.
yes, there you go.
Can you hear me now? Can
Yes.
you hear me?
Yes.
Oh, good.
Absolutely.
Well, I've been on since 5 to 3, but for
Yes.
some reason I wasn't connecting, so I switched from my computer to my iPhone. Anyway,
Perfect.
I'm Sally Pipes, President, CEO, and Thomas W. Smith Fellow in Healthcare Policy at Pacific Research Institute, a position I've held since 1991. I came from Canada. I'm a Canadian. I'm an economist. I've worked on healthcare reform policy since the late 80s. So I'm really a policy person. I've been trying to educate Americans on why we don't want a complete government takeover of our healthcare system. I want to have all kinds of different flowers blooming so that people can get the kind of healthcare that fits their needs and those of their families. My latest book is
Or what
called
they can
False
pay for.
Mhm.
Yes. Yep. Yeah. Well, yeah. But if we have a lot of the options that are out there, different people are in different situations, and so different types of healthcare plans will be good for them. So I think that's important. And my latest book is called False Premise, False Promise: The Disastrous Reality of Medicare for All. So I'm like Phil Kirpin. Phil. You're not alone. I'm on board with you. I'm a free marketeer and have been for my whole life. So anyway, and on education, I just wanted to add that because I've been listening to all of this, you know, the numbers that Phil just talked about. Yeah, a CDC report last month found 1/4 of adults from 18 to 24 had contemplated suicide in the last month. There's a high degree of depression among people out there that are stuck at home. I mean, if you're stuck at home alone. So, but I do think we have to get our kids back to school. It's worked in Europe. The British kids are now going back to school. We really need to do a lot of work to get our kids educated to compete in the global economy, and the STEM programs are very, very important. So I want to get kids back. And the other thing is different choices in like charter schools, school choice, private schools, parochial schools, public schools, all types of schools. Let's have the best type of school for the family and what they want for their children.
Yeah, and I think I do agree with the general discussion around bringing kids back to school. I do also feel that we need to share data that the Journal of Pediatrics did come out that, you know, the kids carry a lot of viral load in their nose. And yes, we have not seen contagion from kids to adults, partly because we have been also somewhat in shelter in place. Being a physician, I do need to bring all of these perspectives to the table. The condition is very new. It's unfolding in front of our eyes. And as kids are going back to school, only then we'll find out contagion and how it happens. But other countries, when we code other countries, we also need to see that the public health policies and the on-the-ground policies that were put in place were quite protective and quite widespread across. So if you look at South Korea, their school opening was very well orchestrated. The schools have proper guidance around what is the proper epidemiological methods to put in place so that the infection doesn't spread. Our guidance is not standardized across schools. So what Bambi was mentioning is that a charter school may have something going on, the private school has something else going on. We need to have proper guidance and proper rails in place so that if there is a case indeed, how do you address that? We have failed that in public setting, in a public health. How would we do it in a school health setting? So that is kind of those are the areas that we are discussing it. Do we really have solid policies for all kinds of schools? And are these policies being implemented? Yes, we all, I'm a parent myself. I want my child, he's a senior. This is the most critical year for him. And this is going to be a make or break year for him. I want him back in school so he can go into sports, what he was doing. He can go into resources, what he needs for his college admission. But I also am not sure that his schools are having all of the proper policies that CDC has provided guidance, but they're not following what I would like them to follow as a parent. So how do we have that transparency on communication? Phil, you had a conversation with this school. Do you get, do they share these kinds of information with you? What are the things they're putting in place for the safety of the kids?
Well, my kids go to a Catholic school, and we have a problem here in DC where, you know, the public schools were closed by the mayor, even though our health metrics indicated they should be open, because they had a labor dispute with the union, basically saying we don't want to work. And then sort of after that, in order to avoid the embarrassment of private schools operating normally while the public schools are closed, they quietly put out a hard class size cap guidance of 11 students per class, essentially prohibiting full-time operation of private schools, despite us having prevalence of, you know, less than 7 cases per 100,000 right now in DC. So even California would let us open, but because of the politics and the situation we have with the public schools, they sort of crippled the privates. And it's, you know, my problem with what our school did is he kept saying, I made this decision, even though he didn't, which makes it very hard for us to sue the city. I just think, you know, after planning all summer to open normally and then having this, you know, this bomb dropped, essentially quietly posted on the website with no explanation, defense, or justification, he should have just told us what happened. And we would have got this parents to sue, and we would have had a lot more recourse. So that's kind of why I was really upset. But, you know, I am not as impressed as you are, I guess, by these lab reports that do, you know, viral load measurements. They all seem to me to add up to, you know, at best, starting with the Drosten paper, which ended up being sort of revised into nothing after his initial splashy claims that got headlines in the New York Times and Guardian, and his math was all wrong. I mean, even if they were true, and I question, I think all of them, the Chicago one, I think all of them have had their own problems. But even if they were true, and the Chicago one, by the way, that was in JAMA was only symptomatic children, and it was only under age 5. So it doesn't really have any direct bearing on the school's issue anyway. But, you know, even if those were all true, even if you did find very high viral loads, and we had another sort of fake thing with Mass General where they put out this silent spreader press release, then deleted that headline later in the day and said, actually, our paper didn't support the original press release, but it was already in newspapers all over the world. Look, even if you did have high viral loads in children, that wouldn't change the empirical observations we have now, not just in countries like Sweden that literally never closed or put any containment in and had no issue, no problems, and 0 pediatric COVID deaths. But what we've now seen across the South, I mean, we have school districts open in places like Georgia now for 5 weeks with no issues, in Texas, and we have these places that have very high prevalence that were just opening, while places in the north were like freaking out with super low prevalence, saying we can't do it. And so I think that, you know, even if there were a high viral load, there must be some other reason that they're not transmitting. The empirical evidence still is what it is, and therefore, if the mechanism is not low viral load, the mechanism must be something else, but the empirical observation is still true. And so to me, in the absence of finding different empirical data than we're seeing consistently in country after country and now state after state, I would conclude that you really don't need containment. To the extent that you have transmission in the schools, it's going to be adult to adult, the same as anywhere else. So, you know, how do you handle dismissal and arrival so you don't have adults mixing with each other? How do you handle staff interactions? You know, the events, the other things you do around the school, the large high schools where you have a lot of people from different, you know, towns across a large region coming together. Those are the things that I would really focus on and worry about. It's the adult to adult interactions that I think are going to be a driver if we do have school-based clusters, because based on what I've seen, I think we're putting our children through a lot for very little, if any, benefit with the containment that I see going into the schools. So that's my view.
Let me,
yeah.
Go ahead.
I'm just curious. I mean, I think clearly college students are different. It's like, you know, exactly how that works by age would be really interesting to know facts about.
Yeah, one of the things that's annoying is almost all the papers on this have these large bins. So they're like 0 to 10, 11 to 20. And for that reason, and I wish they would release the underlying data set so that we could get continuous variables and try to figure out where the breakpoint is, but states are not releasing the data with a continuous age variable. And I don't know if that's because there are data privacy, I don't know why it is, but almost, I can't think of a single data set that has age as a continuous variable. And so it's been very difficult to get at that crucial question of, when do children start to not be children for transmissibility purposes? And I don't think we have a good answer to that. Clearly, we clearly have more transmission in high school students than grade school students, but like, where is the break point would be something really, really good to know. But so far, everything I've seen has bins that are not really conducive to figuring that out.
And can I also just,
Joel, okay, I was going to bring you in, Joel. So.
well, let me just add to that, because I'm facing almost the mirror situation that Phil is. I'm in Virginia, and the public schools here are closed. The private schools are open. I spent this morning taking temperatures of first and second graders as they arrive to our schools, and there are ways to do this safely and to follow the guidelines. And I guess the challenge here is either we believe and will abide by the guidelines, or we won't. Like, we'll make up our own standards and then use those to justify shutting down schools or shutting down elective care or other things. Is kind of the first point. The second point, though, I would say with respect to the college student stuff is, again, there's this sense that because someone is infected, a catastrophic event has taken place. And what we see in younger people is that, in fact, if they're infected, a large proportion of them are asymptomatic. They never go to the hospital. They never die. There's a very low fatality rate for folks 25 and under, and even 40 and under. And so we need to rethink what are we actually trying to get at with these standards and with the data that we're actually getting based on COVID. And I think the policies that are flowing out of some of the places that we see where we need to shut down and remain shut down, or we can't reopen the schools, or University of Alabama has had a major outbreak, and so we've got to quarantine the entire student population, doesn't make sense. What we need to do is take this data and get much more precise and use the technology that we have to be able to slice and dice the population to have a precision-based policy where we can say, okay, in this school or in this grade or in this zip code, we can have a policy. We don't need to shut down an entire state or an entire university because 2 people were infected.
I mean, I think the point you're making, Joel, is that if we had consistent goals, which everybody has goals, then maybe we could actually look at the data correctly and not use the data to support our goals. So we all have to be on the same page about goals. But I wanted to bring Duncan in because I know one of the
I'm just trying to get straight data. I mean, we're not even operating off of accurate, good data. No one's going to the CDC website. They're going to the Hopkins Worldometer, or they're going to the COVID tracking project. Because the CDC and the states and the localities kind of make up their own rules. So we don't have standardized data in terms of case reports or some other things that are critical in assessing where we're at and what we need to do in response.
Right.
The CDC put out a lot. For instance, the CDC has improved a lot in that regard, Joel. They put out a lot of new data sets this week that I've been going through. And so you're definitely making strides. Check out a lot of they just posted a national case line file for the first time that is really interesting. And they've sorted 3 or 4 data sets in the last few days that you should take a look at. So they're getting better. I agree with you, but it's the idea we're all using the Atlantic magazine most days is, I guess a great credit to them, but pretty pathetic.
Well, then how do we get a better job, Phil, and everybody else from the CDC saying that 6% of the COVID deaths are COVID only, where the rest are comorbidities? Now, Archana and I talked about this because she is a physician and she understands there's lots of discretion when you determine what the diagnosis is of someone's death, but we should have those numbers correct. Right?
Well,
it's not just death.
It's just misunderstood. That page That
Yes.
page is talking about what's listed on death certificates. And
Mhm.
you wouldn't expect a classic COVID death to have nothing else listed on the death certificate. You would expect it to have ARDS or pneumonia or something else along with it, which most of them do. And so I actually find that page very interesting, not because of the 6% that list nothing else, but because of the 5,000 deaths that have accidental injury or poisoning. And the dementia number is very, very large. And so it's a very interesting page, but the 6% listing nothing else does not tell you very much. That's been distorted.
Well,
There's
and
also
also
the long really
haulers.
briefly.
Yes,
Yes,
yes.
the long haulers,
Mhm.
all the other problems. It's not simply death that's a problem. It's all the other stuff that comes with it.
Yes.
I want
Well,
to bring in Duncan because I want him to talk about, we talked a little bit about the standards. I mentioned that having the same consistent goals. And at one point at the start of the year, we had a consistent goal of flattening out the curve. Now it's about zero cases. And there's a challenge with that, right, Duncan? So can you elaborate a little bit on that conversation you had with Steve about that?
Yes, let me start off first just by saying that I would like our country to follow real data, get real data, and make decisions, but I don't think that is what's going on here. I think, in effect, we're making decisions on bad data or speculation, not good data. There's no question, Esther's right, that COVID is not a flu. It's got some other weird problems like the long haulers. But there's also very little question that the data we're getting is very skewed. I mean, what's the estimate on false positives from the PCR test? 30%. So the case numbers may be really high. So look, how do you get past all this? I don't know. We're in a weird time. I mean, let's go through the flatten the curve thing. One of the questions I was asked is, and people have thought about this, why don't we just do a shutdown for 2 weeks? Why don't we just shut it hard? No travel, nobody moving around, everybody stay at home, and then the virus wouldn't be able to spread. And my answer to him was, well, theoretically, if we could actually do that, that might sound great. But first of all, will people comply? And secondly, what happened when we did the shutdown to flatten the curve is we shift the goals. So the 2-week shutdown to flatten the curve for the hospitals worked. But what happened? California is still shut down. Not just these guys that are sort of weird. We're still shut down 6 months later to try to prevent any infection. And so what I do, I mean, Phil, you're tracking the inner Scott Atlas and doing a great job. I really love your data and analysis. What I've been looking at is excess deaths. So if you think about, okay, maybe 6% are just COVID only and there's morbidities, blah, blah, blah. At some fundamental level, what is the level of deaths over the normal level of deaths? What are the excess deaths called by COVID? And when you look at that chart, it's quite fascinating. We are about to approach, if you do flu plus COVID above normal, we're about to hit normal. Now we may go back up again in flu season, but that to me is more useful data. COVID really was the worst flu season since maybe 1957 or 1968 or something, so it was bad. And we shouldn't try to say it wasn't bad and try to skew the data to say it wasn't bad. My view about this is the CDC, well, the heritage thing was very good. Why don't we actually follow the law that was passed in 2006 and repeated 3 or 4 times and try to get a modern data system and have metadata? By metadata, a lot of times people drop deaths or they drop cases, but they might be 3 weeks old. Just the data came in, suddenly there's a skew on that date. Oh my God, things are getting worse. Maybe not, maybe it's 3 weeks ago. Metadata on top of the data of when the case happened or when the test happened or when the death happened, what were some of the other factors would be very, very useful. And you know, we sit here all the time in Silicon Valley doing stuff like this. This would be not hard to do from a technical point of view, and probably a little harder to get hospitals to comply with it and other places like nursing homes that should report deaths, because hospitals are still in the normal business using fax machines. I don't know if you know this. You probably know this. Some of you know this.
Yes.
Yeah, they still use fax machines to send like case reports and files and all that. Oh my God. Anyway, well, we should be able to create a system that can deal with fax machines as well as digital information in a much better way. So look, Bambi, my big thing in that whole discussion I had was this. What we're seeing in the US is profound institutional failure. And the CDC failed, the health department failed, and what Human Health Services completely failed. They haven't implemented this stuff. You know, the whole thing with the people trying to do the task force, and then Trump would get in front of it. And when Trump's in front of something, the media amplifies it. So the media failed, and Trump getting in front of it failed. And we had amplification and total distortion. And so what troubles me more than anything else is, why did our institutions behave so badly? I never thought they would. I thought our institutions behaved, not that they're perfect, but they at least would have behaved. We apparently had a really good pandemic plan from 2004, 5, or 6 or something. Where was it? Why didn't we put it in place and implement it? I think Obama, after the 2009 flu, H1N1, also put another pandemic plan out. Where is it? Why don't we say, let's get the plan out and go do something and follow the rules? We didn't do that. We just sort of ad hoc'd it into idiocy.
And it seems like we intentionally did not follow some of our previous guidelines and infrastructure that we had in place. And speaking of sort of policy and data, since the House passed the HEROES Act, one person has died every 2 minutes from the COVID-19 pandemic. And the reason why folks were going to the Atlantic, the COVID tracking project at Johns Hopkins, was because it took months. I was one of the people, along with several of my colleagues, writing to the Hill, writing to the administration for the CDC to release data. You know, data in some states is still incomplete. We've come a long way. So I think we have to actually look at the reason why we have, this conversation around data. The CDC has definitely had some inefficiency. So in May of this year, they released the administration released a testing plan, but it lacked an actual national testing strategy. At Families USA, we released a report that showed that plan sort of lacked the coordination at the federal level that would drive a targeted and flexible strategy across the country. And it also lacked the national bargaining power for testing supplies and materials. So I think we have to look at the lack of national leadership and the disbanding of infrastructures that were put in place before this pandemic, and not really sort of lifting up our most powerful tool in the US, the CDC.
Well, that's a good question. I guess the question is, what can we do on a national level, because healthcare is quite local, and so the states and the cities definitely have their a lot of power to implement their. They might not have the money, but they do have the power. But what, I guess, on a national level can you do? What could be, what should be the national, and what should be the state and local authorities' decision making? What should be handled by the states and the cities?
Can I jump in? I think that Amber, I completely agree with you. I think the problem goes back much further than this administration. In the paper that we released from the Heritage Foundation, Congress saw this coming, and they saw it coming after the anthrax attacks and 9/11. They passed a law in 2006 under George W. Bush that said the CDC ought to create a national biosurveillance network that was made up of interoperable data and linked together so that we could get a good sense for what was happening on the ground. And there would be some source of truth, right? And that data would be looked at in a collected and analyzed precisely, so that we could inform three things: a public health response, public policy decisions, and frontline clinical care that would be informed by best practices. And that was in the law that set a 2-year deadline. So that was supposed to have been built by 2008. CDC failed to do that. So Congress passed another law in 2013, providing funding and benchmarks for progress. CDC failed to meet that law, and so Congress passed another law in 2019 and said, we really, really mean it this time. And CDC's, that law basically said you have to hire 30 biosurveillance data experts to help create this network in this system. And just a couple months ago, Senator Richard Burr asked Director Redfeld, how many people have you hired? He said, I don't know, I got to get back to you on that. And the answer was none. And so if your boss gives you a job of hiring 30 people, and a year later, you haven't even written the job description, I'd say there's a problem with leadership, but it goes back 14 years. And, I don't know what to do if and Congress passed another law in 2020 to give $1 billion to the CDC, to state and local governments to modernize their data frameworks. What happens when CDC ignores the law? What happens if we're just going to put more people on the ground instead of getting smarter about using existing data and existing EHR and claims transactions to automatically extract data rather than have it entered 2 and 3 times in a very inefficient and inaccurate way? I don't know. What we've called for in the paper is to say every week that HHS fails to implement this law, their budget should be reduced. And if that doesn't get their attention, I don't know what will. But
hey, Joel, I have a suggestion.
Yeah.
You're basically saying institutionally the federal agencies are not going to do this for whatever reason. You can speculate why, but it's under both both parties, 15 years, probably longer.
3 administrations. Yep.
There is an alternative. So if you look back at when the EPA was formed in 1970-71, there were state level EPAs. And there was sort of a pressure to create a national thing to coordinate them all. This could start from some of the state government health departments saying, we need to collectively create this system. And if the federal government gets in the way, flipping the bird. I mean, maybe some way to get this thing solved. But
or the other way.
I'm appalled because PPE, right? The PPE, we have this huge stockpiles. They were somewhat depleted after H1N1 and they weren't repaired. And you have examples when China sucked us dry of PPE, we only had 1 manufacturer left in the US. And we went into these stockpiles and they weren't well maintained. It's kind of like I'm saying to myself, okay, people, somebody has one job, maintain this, and they failed to do it.
Hey guys,
at some level, the human element is uncontrollable, but maybe the
I'm late for a back to school Zoom, so I need to meet one of my kids' teachers on a Zoom, so I need to leave early. But I just want to end with 2 things before I go. One is, I'm sorry if I came off angry or aggressive or frustrated. It's because I am, so I apologize for that. I have nothing against any of you. I love you all. Everyone has said wonderful things, and I meant no offense to anyone if I did offend. And second, I really enjoy that bashing the CDC's total failure unites left, right, and center. And that we can all agree on that. And with that, I will take my leave and thank you guys.
Okay, thank you all for joining in. Yes, thank you. Hey, so we can maybe frame this question slightly differently. So we can kind of go around the panel and ask what really worked well. And I know it is hard for us to see that. And what are our learnings that we could not only learn from internally from our failure, but also externally from the European CDC, how well they performed, even Canada, how well they performed. They are under a case per 100,000 in the last 7 days. That is incredible for a large country to be able to do that. So let's kind of go around the panel and ask, like, what has worked and what are our learnings and what can we do differently as we go forward. So I'll begin with Amber again, because you're on the first tile next to me. So yes, what worked and what didn't work, and what are our learnings?
I feel like I needed a little bit more time to think about the first part of the question. I would say, and I know this is not I don't know if this is directly answering your question, but I think what we have seen is a sort of resurgence in civic engagement and advocates being vocal about what the needs are. We're seeing multiple pandemics right now, not just COVID-19, but the impact of structural racism. So I'm encouraged by that renewed energy of civic engagement and what that will look like in the months ahead. I think some of our learnings are, and I'm going to reference a title of a report that I co-authored at Families USA, borrowing from Dr. King, The Fierce Urgency of Now. There is a such thing as being too late. And I think we have seen some of the effects of that. So that to me is one of the main learnings. We can be too late. Americans are dying, Americans are losing jobs. This isn't just a health crisis, it's an economic crisis. So I think one of the learnings is that we have deep inefficiencies in our healthcare system. And this is a time to have a real conversation about strengthening our health and healthcare system. It's not just what happens in the four walls of healthcare, but what happens outside that impacts health and health outcomes.
Great, thank you. And Joel, you're next on the panel.
Yeah, I think telehealth has worked really well. I think that what we saw when HHS shut down, the elective care, we saw this massive spike in telehealth to step in and kind of fill the gap. It didn't completely fill the gap because it's hard to deliver chemotherapy remotely. But what we saw, just one company went from 1 million telehealth visits in all of 2019 to 9 million visits in 6 months, in the first 6 months of 2020. And that's just one company in the Medicare market alone. And so it really kind of stepped in. And what we're seeing now is the trend starting to come back down as in-person physician visits go up. There's two reasons for that. First, it's still a presence because we have flexibilities in place that the federal restrictions on telehealth have been temporarily relaxed, but the reimbursement has not matched what we need to kind of tip the scale between in-person and remote visit. And so if we want to continue to incentivize the things that can be done remotely, whether it's remote monitoring or telehealth delivery or other digital strategies, we're going to need to create reimbursement structures that incentivize the uptake of those things. And while continuing to recognize we very much need to create new models around in-person care, including safe zones around like dialysis and chemo and other cancer care, so that if we continue to experience the negative effects of the pandemic, people have a place to go. It's kind of like a Israeli airport safety zone where a cancer patient can go to get their chemo without fear of being infected. And so if we have those three kinds of systems, the infection system, the acute care in-person system, and the digital system, I think would be a lot better situated to deliver care to folks in need.
Awesome, thank you. Duncan, what do you think worked well and what is your wish list?
Well, I think stopping the flights from China early probably saved California because we had a lot of the Wuhan flights. I wish we had stopped flights from Europe earlier. And also, New York Times had a great article on how the Wuhan strain of the virus that came out of Europe then spread around the US from people fleeing New York. And so we probably should have done more there in terms of restricting travel, at least during the critical period. Second thing that seemed to work really well, some of the states isolated the elderly. Instead of taking them out of the hospital to save a hospital and putting them back in the nursing home, which turned out to be a total disaster, they created isolation centers that were designed to take the infected and keep them away from. That worked really well. The third thing that worked remarkably well, and I don't think it's given a lot of credit, it's like picking up on Joel telehealth, but the speed with which certain private institutions responded, like Uber Eats or getting food delivered from restaurants. Yes. The speed with that, the speed of Zoom, the speed of us adopting remote work. I mean, our office shut down in early March before California did its shutdown, and has been remote work ever since. And we're kind of surprised that you can do whole deals remotely. That all worked really well. So the 40% of the white collar part of the country very quickly were able to migrate. So I would say in general, certain sectors in the private sector responded very quickly and very well to this. The third thing I think's responded very well, again, private sector, there have been a lot of very good moves to fix certain flaws. So restaurants reopening with glass frames between them, or places you go up to the counter having the shield. After we had the initial stumble, the production of private tests, because CDC's tests were contaminated. You can go through a bunch of examples. So I would put those examples into number one, the private sector responded very well for the most part. Number two, people actually adopted very quickly, at least some segment of the population. What's my wish list? I'll go back to what Amber's talking about. I'm appalled at how many both African-American and Hispanic people are dying from this because of their conditions of living and health. It's like, it's exposing a great gap in our health system it should be looked at and frighten people. This is just not right. And I'm actually very, very concerned. It's been noted, but kind of brushed aside as unimportant. the whole segment of the population is much more at risk, and they're usually doing the essential work. That one really strikes me as bad. The other thing in my wish list, I wish we could bring a lot of the manufacturing back to this country of things like PPE or pharmaceutical products. In other words, we now see that when a pandemic like this hits, you can't rely on China to deliver the stuff. They were sucking their own use. We have to have it here. So my wish list would be we build up our manufacturing base for certain essential items much more quickly.
Great, thank you. Sally.
Right, thank you. All very good ideas. I'm very much a huge promoter of the private sector, and what we just heard, I mean, it's amazing. I live in Pasadena in the Los Angeles area, how, you know, restaurants are still not allowed to open and have in-house dining, but most of the restaurants now have, you know, little places out on the street and outdoor dining. Of course, our weather is perfect for that, except for the fires that are going on right now. But really, the private sector in all aspects, whether it's developing a vaccine, antivirals, these things are being developed by the private sector, and we want to keep that alive and well, because that's where you know the vaccine will come from the private sector, and in some cases with the help of the government. But we need to have this market open so that it can continue, so that we will, you know, have advancements. I totally agree with the whole idea from Joel on telehealth. I've been pushing telehealth for many, many years, and particularly for older people who are afraid, you know, to go to the doctor, or because they might get it in the doctor's office, they don't have transportation. This is an idea that has long been coming, and I'm so hoping that it will continue after the COVID pandemic ends. I've seen some great things in terms of physicians' assistants and nurse practitioners being able to do things. They're very well trained, that only doctors have been able to do, and doctors don't need to do a lot of those things. So it opens up the market for doctors to take care of patients that really need care. I'm Canadian. You know, the Canadian healthcare system is totally run by the government. There's no private healthcare in Canada. 323,000 Canadians cross the border every year and pay for MRIs, CT scans, that they feel the waiting time is too long. Certainly, we've seen, while there haven't been as many cases of COVID in Canada, because of it, we have 100,000 surgeries and treatments have been canceled there, and they're saying it will take up to 2 years to get rid of this delay. So we've seen a lot of delays, not just in Canada, but in the UK. They have 10 million people on waiting lists now. They say it's going to take over 4 years to get rid of those delays. So, you know, it's very, very important that people have access to treatments. I mean, the media has scared people to death, but when you look at stopping elective surgery, they say chemotherapy is elective. We need people to have access to getting their mammograms, their colonoscopies, their CT scans. The journal Future Oncology found that of the rate of cancer screenings in this country dropped 90% in April compared to February. So, you know, this is very important. People need to get access to good care. I mean, it's more serious if you need a biopsy or you have cancer diagnosed and you can't get treatment. I think it's more important to our population than the number of people who are going to die from COVID, because as we know, most of the deaths have been of the senior population, and particularly people in nursing homes and long-term care. Young people, you know, go out and party, and most of them don't die. They party and they get over it. So I see a lot of room for more telehealth, more changing the licensure issues so that docs can practice, not just if you're licensed in California, but in New York or Idaho or wherever, using nurse practitioners, and really making people know that they have to get their treatments and they shouldn't be afraid just because of COVID. We need, you know, if people do social distancing, if they wear their masks, I mean, these are all things that are going to help get us over. But the private sector is bringing the solutions to this terrible pandemic. Thank you.
Thank you. Esther, what's your perspective? What's working, what's not working?
The things that are working have mostly been discussed, and it's amazing how fast the private sector has responded. Telehealth, you know, the rich people are doing a great job of working from home, but this whole thing has exposed the huge problems. The private sector responds with solutions, but we need the public sector to invest in eliminating the problems in the first place. And that's the big divide. The private sector is not fixing the racial divide. It's not healing the poor people. It's not taking care of the schooling of the poor kids. It's not really helping the essential workers. And so we've got a great private sector. We need a much, much better public sector, starting with the CDC, the education system in the US, all these kinds of things. And what COVID-19 itself has done a really good job is making all that clear. So I have 3 points of what I'd like to see, or 3 points I'd like to make. One, the problem with the opioid crisis is not the people dying. It's the people living with addiction. And in the same way, the problem with coronavirus is not the number of deaths or even the number of excess deaths. It's the damage it causes to the people who are sick and to the people who are around them, who may miss school, who become victims of domestic abuse. I mean, it's exacerbating all the cracks and fissures we have in our society. What I'd like to see come out of this is that we train. There's lots of people out of work. We should have a massive training program to train them to be care workers. You know, not everybody, but there's going to be a huge need. There already is a huge need for care workers that's unfilled. It's going to be even larger with all the people suffering from various kinds of post-trauma, whether it's physical post-trauma or mental. And we need to pay them and give them dignity and help them have good health care and education so that they don't become the next bunch of essential workers who get sick. And while we're at it, if we tax sugar, I'd be really happy. So thank you. And by the way, this has been just a wonderful, wonderful session. I mean, I'm sorry that it doesn't have a great audience, but I have learned a lot. I've enjoyed it. I'm delighted to meet all of you. Just thank you so much, Bambi and Arshana, for setting this up.
Well, we wanted to be bold and courageous in bringing such a topic to the forefront, because I think as much as we are in the election year, as much as we all want to talk about election and you know what's on the ballot, but we wanted to focus on to healthcare and the policies and the politics that impacts each one of our lives, and in a nonpartisan way. So thank you, each one of you, to participate in that and keeping the arena as election free as possible. So thank you very much. And you know, with the same questions that we ask you, I want to ask Bambi the same question, and then I would like to also share my perspective as a clinician, as somebody who's a population health strategist for HP, knowing that one of our factories are in Wuhan, is in Wuhan, and I have been very up close and personal with the response team from day one when it started. So Bambi, I would ask you what worked well and what didn't work well, and then I would close out.
I know you were going to pose that question to me, but
Yes.
but I will say that thank you, Esther, for this. This is our kind of Q&A discussion. So the main event is October 7th. We like to just have these extra ones just so we can all get to know each other. But I would sort of, like Sally said, everybody had great points to make. I think telehealth was, Arshana and I have been covering lots of virtual care. So obviously we've seen a lot of advancements that could have happened over 10 years consolidated down into 3 months. So I think we did that really well. And then we focus a lot on mental and behavioral health, and I've been focusing quite a bit on that. So I think what I've seen from a humanity side, I think I've seen the best of humanity and the worst of humanity. And I will say that one of the things that I like is the resiliency and the creativity that I've seen out of everyone, like the small businesses you've mentioned. It's just fascinating to walk around and see how they're doing haircuts on the street, or they're putting barriers up, or they have all their different things just to try to make a living and just to try to make it work. And I'm seeing kids do that as well. I think on, the worst side, obviously with social media, it's the only way we can connect, but I'm seeing the worst of all personalities there. But the silver lining, and Amber kind of mentioned it on kind of struggling and understanding our human condition. I think that something that we have avoided for probably, the long 18th century, which is the age of reason, or some call it the age of slumber, when we stop thinking about our human condition and who we are deep down inside. And I think what COVID has done is made us think about who we are, good and evil, all of those questions that we typically push aside because we want to focus on capitalism, making money, which are all good things as well. But I like watching people struggle with those questions. Not that I want to see people struggle, but I think it's a good thing that we're actually embracing that, and that'll lead us someplace to a better place of understanding who we really are.
Thank you, Bambi. And I do thank you all for sharing what worked and what didn't, because it's always good to do the check and balances, because not everything is doom and gloom, but it is good to learn from it. So personally, I feel that a private sector, which we have fueled with innovation and ample funding, and is flush with funding, I would say, performed really well, because it can. It is enabled. It is enabled with policies. It's enabled with minds and innovation, and the cream of talent that's sitting in the private sector. And it did perform really, really well, whether it's telehealth or coming up with vaccines, or even going as remote workers and still keeping their salaries and food on the table. But what it did expose is how we have never really invested into our public infrastructure and social infrastructure for several years. And COVID has laid bare that in front of our eyes. As a healthcare worker, I can share this with you, that we found our nurses who were trying to save lives reused their PPE devices and got killed while catching the COVID-19. And we didn't pay attention to that. We never paid attention to how to enable supporting a public health system in which we could do contact tracing. We don't have contact tracers. We don't have tests available for each one of us. So no matter how good and outperforms our private sector, if we do not have the public sector catch up to that with the amount of infrastructure, the data, what Duncan was mentioning, the data carries a lot of weight, and what Joel was mentioning, that all of these years of flush funding that CDC got and policies that were in their favor and they underperformed, not holding them accountable, is now showing up in the form of almost 200,000 deaths in front of our eyes. And some of these are essential workers that gave their life while they're working for our patients. So it is, the public sector didn't do well. Our social sector, social infrastructure did not do well for folks who needed more attention. We already knew that we're not doing well with our underserved population. And of course, we know that there's higher mortality in that. And that is trickling down to our schools. School is part of our public infrastructure, and it's suffering. It is suffering because we never focused on our public infrastructure. That's our Achilles tendon. That's our weak link. So maybe hopefully as we walk away, we see that we are strong, we are really strong in our private sector. Well, maybe we can use all of that knowledge and innovation to flush our public infrastructure, so we can have the same advantage next time around we encounter a similar threat to our population. So hopefully, from a clinician's perspective, that is not so doom and gloom, but I definitely want to walk away with that learning, that it both counts about the same for each one of us.
Thank you.
Thank you
So with
all.
that,
Thank you.
Everyone, October 7th at 12 p.m. PST.
yes.
See
PDT.
you there.
PDT. PDT.
Tootsville.
whatever.
Okay,
Yes.
goodbye, everybody.
We're looking forward to seeing you all there.
Thank
Thank you.
We are too.
Thanks a lot.